Perfect. And so that's a great segue to talking about calcium, and I'll talk a little bit about dealing with severe calcium and this issue that comes up in all of these CHIP cases as a whole. This is just a case to start off with of a woman who had typical symptoms, had her LED stented, and unfortunately at the time the stents delivered fine, but there was difficulty expanding the stents. And so she had progressive exertional angina. It was known the stents were difficult to expand. She was brought back to the cath lab, and because of further inability to expand, rotational atherectomy was done to try to ablate the stent. And despite successful atherectomy with a 1.5 millimeter burr, still could not expand the stent, and she continued to have exertional angina. She then came and was transferred to us, or came electively to us. And I think you can appreciate in her proximal LAD, that area is stented. It's not fully stented because the stents have been ablated somewhat. There's severe and dramatic underexpansion of the stents. Ziad mentioned that it's hard to tell in many cases whether it's underexpansion or neointima. This is one where you can tell that it's underexpansion because you can see the vessel constrained itself. So, as we always do, we try to IVUS first or to image first to see what's going on, and in this case the imaging catheter wouldn't even cross. We then were able to take balloons down, and with an NC balloon at 30 atmospheres 4 times, still could not expand. So we thought maybe it's the one company's balloon is not good, so we chose another company's balloon, and still the same thing happened. You can see the residual waste there. And so with that in mind, the only other thing to do at this point, besides further and larger atherectomy, is we chose laser. And with contrast laser, we were able to successfully expand the stent. This is a 3.0 at 26 atmospheres, and then the final result was achieved, which is angiographically quite satisfying because the laser essentially created a shock wave to expand this stent. So is this case more broadly generalizable? Do we see this? Is this a sort of a unique unicorn type of case that I'm showing? Unfortunately not. These cases are more broadly generalizable, and we're seeing more and more of them in our cardiac catheterization laboratory. And the reason is because our stents are better and better. They deliver to places, but yet you get in-stent restenosis. We were actually joking just before that instead of calling it in-stent restenosis, there are cases now where you can call them instant restenosis. That's his term. And because you know that the stent is not expanded and you got it there, but this is a problem. So this happens most commonly in calcified lesions, and Ziad mentioned that in his last talk. One, how frequently does this occur? Even in trials that tried to exclude severe calcification, we see calcification in up to 29 to 30% of cases. We observed this also in a larger registry of patients, 30% calcification, but in the CHIP population in particular, you see even higher rates. So this is published data from the Syntax trial where heavy calcification was seen in almost 50% of the cases in the trial. So this is something that we have to deal with, and we need to be primed to deal with it. Who are the types of patients? Older patients, post-CABG, renal failure, diabetes, those are typical tip-offs that you should be thinking about calcification. One of the things for the residents and fellows is that if you have a patient like that, you need to really focus on these types of things, because if you neglect the calcium, you're going to have problems later. Now, fortunately, you can detect it reasonably well with angiography, but there are other ways to detect it using OCT and IVUS. This series from Japan looked at patients that had all 3 imaging modalities, and it turned out that if it was detected by angiography in this particular series, that was what affected stent expansion. But I can tell you that if you look at unselected cases, there are going to be cases where you don't detect it angiographically and you detect it by imaging, and that can have implications. So what are the implications of coronary calcification? Well, first is expansion. Everybody knows that it's harder to deliver a stent when there's calcification, and most people fixate only on that. But more important in some ways, in my mind, than delivery is expansion, because it's actually worse to deliver the stent and then have it not expand than to not have delivered the stent at all. That's a really, really fundamental important point. And the reason for this is because basically as you get more and more calcium, it's a rock, and so the stent tries to expand and it simply can't do it. Ziad mentioned a little bit about fracture. This is an imaging study from Japan, and this was also shown in the main hall yesterday, that basically if you achieve fracture, you can get better expansion of the stent. There are other ways to predict this, and Ziad showed this, so I'm not going to go through it in detail, looking at scoring systems, but the bottom line is that if you have a thick amount of calcium, concentric calcium, long length of calcium, it's going to be less likely to expand with balloons only, and you typically need to think about other techniques in those circumstances like atherectomy. Now, calcium is also associated with bad outcomes. Ziad also touched upon this, basically worsening rates of TVR, death, MI, seen with calcification. And it's not just because of the patient population, it's also because of what happens once the stent goes in. This is just an analysis from drug-eluting stent trials, 2 trials, that showed that not only was there increased target vessel failure rates, but in addition, stent thrombosis rates were higher in the presence of severe calcification. So bad early events in the lab, bad early events clinically, bad late events. And if you think about the rates of TLR and TLF that we're seeing nowadays with contemporary DES, they're really good, 5% or less. This is one lesion subset where they exceed 10%, in some cases up to 15% at a year and 2 years and beyond. Now, how do we treat coronary calcification? There are many options for it. You can use various balloons, including specialty balloons, and you can use atherectomy devices. This is a slide out of the Mount Sinai lab with Samin Sharma and others, basically showing that if you have severe calcification, they default to an atherectomy strategy first. If it's mild, you can try other things, and if it's moderate, you arbitrate with imaging to determine whether those criteria exist or not. Now, the problem is that if you look at the guidelines, and this is a combination of US and European guidelines, basically the highest level of evidence for any device is a class 2A recommendation in these guidelines for rotational atherectomy. Nothing has level 1 evidence. And the reason is because the trials really aren't there. In addition, there are perceptions about complications, and we've seen these complications that can occur with some of these devices. So as a result, if you look at large unselected series, this is the ADAPT DES that we published, you basically see that atherectomy and or specialty devices are used in the minority of patients that even have severe calcification. So what most operators are doing is they're electing to go with balloons, and they're trying to get through the cases, but as we know, that leads to higher rates of potential complications. So what can we actually do, and where are the data? Well, so it turns out there are data for cutting balloon versus conventional balloon. This is a small trial that showed slightly greater lumen areas with the use of a cutting balloon, so this can be useful if it's going to deliver. There are other devices such as rotational atherectomy. This has not been changed since 1993. There's a new system coming soon, but it basically has not been changed since that time. We all know ROTA quite well, but it's a critical component of these chip-type cases. It turns out that the use of calcification or atherectomy for calcification is increasing a little bit, and it turns out that it's also associated with a reduction in complications, at least in this analysis that was just published in CCI last year. Now, the problem with ROTA is that there's no randomized trial supporting it. There was a trial that was tried. Rotaxis tried to show benefits of this, but really showed no real differences in procedural outcomes or even in the primary endpoint of late loss. But it turns out that was probably because the trial included patients with both moderate as well as severe calcification. And if you look at the severe calcification subgroup, there was greater strategy success with atherectomy first compared to balloon alone. This data has also been substantiated in other types of data. This is from Antonio Colombo's group that showed that if you used upfront ROTA versus bailout ROTA, the bailout cases had longer procedure times, more contrast, more fluoroscopy, because basically people were struggling with balloons and then they had to bail out to rotational atherectomy. That's why in general our philosophy is if you think about it, you should use it so as to make your case easier. There is a randomized trial that will be reported out probably in the next year called Prepare Calc, looking at scoring balloon versus rotational atherectomy, and this was done in Germany and completed enrollment in October 2017. Other devices, briefly, I know we don't have access to them here in India, but is the Diamondback 360, which is an orbital atherectomy system. It uses a smaller burr, a 1.25 burr compared to ROTA. And basically with this device, this has been studied in the Orbit 2 trial. There's no foot pedal, there's no gas tanks. And in this trial, procedural success rates were quite high, and late outcomes were very good as well, especially if one considers that the majority of these outcomes were driven by periprocedural events. So this is a device that we're studying actively in the large Eclipse trial, which is a 2,000 patient randomized trial randomizing to orbital atherectomy based strategy versus conventional angioplasty based strategy in 2,000 patients at 150 United States sites. Endpoints that are going to be assessed are OCT based as well as 1-year rates of target vessel failure in all subjects, in addition to the economic utilizations too. We were talking briefly on the panel about the shockwave device. This is a device that's a balloon-based device that then, through ultrasound, emanates shock waves to then fracture calcification. This is just an example of what OCT with this device could look like. The challenge with this device is you have to deliver it to the lesion first. So if you have a very, very severe stenosis, you will have to predilate with other balloons to be able to get this in. But there's going to be more data presented with this device, and hopefully it'll be coming at least to larger studies in the United States relatively soon. So in conclusion, it's pretty clear that the prevalence of coronary calcification is increasing in the modern day cath lab. You have to know how to deal with these types of patients. Calcium is associated with more difficult procedures and adverse short and long-term outcomes. There are a variety of strategies that exist to combat it, but a focus not just on getting the stent there, but on getting it there and delivering it adequately and expanding it adequately is what's really critical. And the ongoing ECLIPSE and the completed PRECARE Calc trial would further define and solidify the role of atherectomy for severely calcified lesions. Thanks so much. Thank you so much for coming to this session. It was great co-moderating as well.
Thank you very much.
And we'll see you in the next hall over.